all short duration fevers do not need laboratory investigations. And most often the diagnosis is clinical and is based on other symptoms and signs. When you have a fever which is not localized to a particular organ system, and therefore the first message which I want to give in my presentation is that please exercise diagnostic stewardship. Do not do tests if they are not required. And what are the causes of acute undifferentiated fevers in the Indian setting? Now, the first is tropical infections. We are living in a tropical country, and we all know that diseases like dengue, malaria, typhoid, paratyphoid, leptospira, rickettsial infections, chikungunya. In fact, as a pediatrician, I often have mothers coming to me and saying that my child's fever is not coming down. So they're worried about that the fever will cause a problem. But please understand that fever is a symptom and not the disease.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Thank you. I thank Medflix for giving me this opportunity to talk about this important subject. And let me tell you that even though this is one of the very common problems that we face in our day-to-day practice, but it is still something which which can leave us thinking about it. So with this, let me start my presentation. So the first important point which I would like to say is that all short duration fevers do not need laboratory investigations. And most often the diagnosis is clinical and is based on other symptoms and signs. For example, upper respiratory tract infection. So if a patient comes to you with fever and he has a runny nose or a cough, then you know this is a viral upper respiratory infection and you don't need to do any lab test. Similarly, if that patient has tonsillar exudates, you know it is a strep sore throat, you can go ahead and treat the patient. If the patient has ear pain and you have on otoscopic examination red eardrum, you don't need a lab test. Similarly, if the patient has fever, severe headache, sinus tenderness, you know it is sinusitis. Again, you don't need to do any lab test. You don't need to do any x-ray, and you can go ahead and treat the patient. Similarly, if you have a patient who comes to you with fever, abdominal pain, and loose motions, you actually don't need to do any stool test or anything else. And many times you have a patient coming in with folliculitis, impetigo, cellulitis, etc. You have other illnesses like in children, we have chicken pox, we have hand, foot, mouth disease, etc. You must have seen lots of cases of hand, foot, mouth disease, again, where you don't need to do lab tests. So a good clinician in most cases will be able to solve the problem clinically and just go ahead and treat the patient symptomatically. Investigations are needed when there are no clues and when you have a fever which is not localized to a particular organ system. And therefore, the first message which I want to give in my presentation is that please exercise diagnostic stewardship. Do not do tests if they are not required, and therefore save money for the patient. And sometimes when you do tests, you're actually confused and you don't know how to interpret the result. So practice diagnostic stewardship. Do tests only when they are actually required. Now with that, let us talk about acute undifferentiated fever. That means this is where we have to rely on laboratory investigations. And what are the causes of acute undifferentiated fevers in the Indian setting? Now the first is tropical infections. We are living in a tropical country and we all know that diseases like dengue, malaria, typhoid, paratyphoid, leptospira, rickettsial infections, chikungunya. In fact, recently we've had a bad outbreak of chikungunya with lots of sick cases, and we all know that even Zika has entered our country. So all these tropical infections cause fevers, which sometimes you cannot diagnose on the clinical basis. Of course, if you have a patient who comes to you with fever and has severe joint pains, you know you have an episode of chikungunya, but you still would like to do a test to confirm the diagnosis. Then you have certain viral infections. For example, in influenza, sometimes in the initial phase of influenza, you may not get any of coryza, cough. Then you all know when we had COVID going around for 2 to 3 years, it would sometimes come with just fever. Now we have stopped thinking of COVID as a cause of acute febrile illness. But during those 2 or 3 years between 2020 and 2022, if a patient had fever, the first test we would ask for is a COVID test. And you all have also experienced the adenovirus outbreak, which we had in the past couple of years, where patients would come with high fevers and no other manifestations, and you tested them, and these fevers would last for a long time, and they had adenovirus. Similarly, infectious mononucleosis can come with undifferentiated fever. And if you are having a prodromal phase of acute viral hepatitis before the jaundice starts, you can sometimes just have fever. And there are certain bacterial infections also which can cause fever without focus, like a urinary tract infection. Contrary to popular belief, when you have pyelonephritis, you may not get dysuria, burning, you get just high fever with chills, and sometimes you may have pain in the renal angle. Similarly, in many patients with pneumonias, you may not get cough. In the elderly people, you can just get fevers and you may have a decline in sensorium, something which is called as an occult pneumonia. And in so many children, we have sinusitis just presenting with fevers and headaches. Especially if you have sphenoid sinusitis, you may not get any respiratory tract symptom. So remember, these are some of the causes of acute undifferentiated fever that you have to think about. And I think I may have missed something. So please put it in the chat box if there's some other illness that you can think about. And of course, there's something which I've missed here, but an abscess, like a liver abscess, can also cause an acute undifferentiated fever, and which will come in the category of bacterial infection. You can have, endocarditis, but then those things cause prolonged fevers. I've not put tuberculosis here because, again, tuberculosis comes as a differential of pyrexia of unknown origin. So we are just talking about short duration fevers in today's lecture. And this is a good study, which was published in recently, where they talked about the causes of acute undifferentiated fever in over a 1 year period, where they looked at 1,500 patients and they did all sorts of tests, including tests for dengue, malaria, scrub typhus, and typhoid, etc. And actually, the causes of fevers will differ depending on which area of the country the study is done, and it will also depend on what season you have done the study. But in this case, the most common causes of fever were malaria, then followed by dengue, then bacteremia, followed by, which was most commonly due to typhoid, scrub typhus, and chikungunya. These were the most common causes of acute undifferentiated fever, which was published from Vellore and other areas. Now, before I come to the lab tests, I would just like to talk about some of the clinical clues which can help you in diagnosing the cause of fever. When a patient comes to you with a fever which is not localizing to a particular organ system. So there can be epidemiologic clues like the geographic, season, and contacts, because all of us know who are practicing medicine that there in a particular season there is one important fever which goes around. Like in the recently concluded season, at least in Mumbai, we knew that the most common causes of fever were dengue and chikungunya. So sometimes, if you have one member in the family having one fever, you know that the other person, if he comes with fever, that is most likely going to be the same cause. So you often ask the patient that, is there any other person in your family who is sick? And if they say that, yeah, someone in my family was recently diagnosed with dengue, then you know that probably this patient would also have the same cause. Now, we are all we often ask for the pattern of fever. And that does help. But remember now, the pattern of fever is confounded by the use of antipyretics, because there is so much fever phobia amongst patients that they are more worried about the fever than the cause of fever. So this is, as a pediatrician, I often have mothers coming to me and saying that my child's fever is not coming down. because they're worried about that the fever will cause a problem. But please understand that fever is a symptom and not the disease. But suppose you have a patient who tells you that my fever was highest on the first day, and now on the third or fourth day, the fever is gradually coming down. Then you know that this fever is more likely to be viral. On the other hand, if the patient had low grade fever to begin with and now is gradually increasing in intensity, then you know that this fever is more likely to be typhoid. On the other hand, if the patient has an intermittent pattern of fever, that he had fever and then he didn't have fever for a day or two and the fever comes back again, then it is likely to be malaria. But this intermittent pattern of fever is usually seen in the later phase of malaria. We often think that if the patient is having rigors, then it means malaria. But understand that rigors can be seen in many illnesses. You can see it in influenza, which is a viral infection. You can see it in pyelonephritis. You can see it in any patient with an abscess, and you can see it in malaria. So, just the presence of rigors does not tell you that your patient would be having malaria. Now, there are some other signs like muscle tenderness. If you see muscle tenderness, it means leptospira. If you have rash, there are typical types of rash you see in dengue. If you see an eschar, you know it's rickettsia. If your patient tells you that the joint pains are severe, you know you've made a diagnosis of chikungunya. If you have conjunctival congestion, you know it's lepto. But there are some other features which are non-specific. So if the patient has cough, it can be present in any type of fever, headache, body ache, vomiting, loose stools. Loose stools, if there are some loose stools, it can be present even in influenza. So those really symptoms don't really help you in making a diagnosis. But if there is a patient who comes to you with a step ladder pattern of pyrexia, who has a coated tongue, who has abdominal pain, who has some loose stools, then you're probably dealing with a case of typhoid. So these are some of the clinical clues to diagnosis. So if you have a jaundice with this kind of conjunctival hemorrhage, you are probably dealing with leptospirosis. This was a patient, a child who had fever, and we had this lesion in the axilla. And the moment we saw this lesion, we knew this was an eschar, jet sloughed off, and we knew we were dealing with a case of scrub typhus. And when you see this kind of rash, this you know that you're dealing with the initial phase of dengue, and this would help you in making a diagnosis. So if you see some of these telltale clinical signs, then you know you have made a clinical diagnosis for the cause of fever. Now let us come to the investigations. Now, the next question is, when should we do the tests in a patient with fever? The tests are best done at 48 to 72 hours unless the patient is seriously ill. Now, why is that so? Because sometimes, your illness may localize at 48 to 72 hours. On the first day, if the patient has high fever, they may not have any cold cough, they may not have loose stools, but on day 2 or day 3, they start getting a runny nose. And then you don't even have to do the investigations because you know that this patient actually has an upper respiratory tract infection, and you can just reassure them, you can give them symptomatic therapy. So that is why I usually delay the test till day 2 and day 3 unless the patient is seriously ill. And also the changes in the CBC which you want to see to make a diagnosis usually happen on the second to third day. The next question which comes to your mind is that shall I do all the tests together or shall I do them one after the other? So all of that depends on the degree of sickness of the patient. Because if your patient is extremely sick, you do all the tests together because you're admitting the patient, you send all the tests together because you want to get a quick diagnosis. On the other hand, if the patient is relatively stable, you do some of the tests in the beginning because you don't want to waste the money. And then, depending on the results, you can order for the next set of tests. The third very important thing is that please do it from a reliable laboratory. That is very important because though the reliable lab may cost a little bit more, but at least the results will be reliable. On the other hand, if you choose a lab which is not reliable, then you may not even get a reliable report, and you may actually, end up paying a lot later. Then another point which I wanted to make is that sometimes a serial investigation may be more useful than a single investigation, and one test which really helps you is the CBC, because sometimes in dengue, when you do the first test, the result may not help you, but when you repeat the test after a couple of days, you can see the classical leukopenia and thrombocytopenia. Another important point which I wanted to make is that do not order for tests for diseases that are not in clinical consideration. That means if you're not thinking of a disease at all, do not send that test, because the positive predictive value depends on the pre-test probability. And therefore, sometimes you see these patients, they go for these health checks, and they often go to the lab and they say, my doctor has asked me to do these tests. Then the lab person will say that we have this whole package. Why don't you do this package? And it will include some tests, like, it will do a LDH for the patient. It will do some other test. And when the lab results come back, they will find the patient will get really worried because uska LDH comes abnormal or something. So please understand that there is no point doing tests for which there is no suspicion for that disease, because if the pre-test probability is low, the positive predictive value becomes very low. And this is just illustrated by this 2 by 2 table. So let us say that we have a disease where the pre-test prevalence is 10%. That means you have a patient with a particular symptom and sign, and the probability of that disease is just 10%. And you have a test which has a sensitivity and specificity of 90%. So normally, a 90% sensitivity and specificity is regarded as a very good test. But when you do a calculation, you find that the positive predictive value is only 50%. That means if that test comes positive, the PPV is only 50%. Compared to this, to using that same test when your pre-test prevalence is 50%, the PPV becomes 90%. So this just tells you that the PPV depends on the pre-test prevalence. And this same concept is used in the HIV testing. That means the HIV testing, that how the labs do it, that if the first test comes positive in an asymptomatic person, then they repeat the test second and third time. Because if the first test is positive, then they do the test again. And if the second test is also positive, then they call it positive. And this is based on the same principle. So after understanding all this thing about the investigations for acute undifferentiated fever, let us talk about the first line investigations for acute undifferentiated fever in the Indian setting. What are the first tests you would do in a patient who comes to you with fever, who after 48 to 72 hours continues to run fever, and who has not shown any localization in the form of cold, cough, or who doesn't have loose motions, etc. So what are the tests which I would do? Would be a CBC with a peripheral smear, a CRP, a test for malaria, dengue serology, especially if it is the season for dengue, which is between June to November, a blood culture, a urine routine with or without culture, depending on what the urine routine shows, a chest X-ray, and an ultrasound abdomen. So this generally would include all the tests which you would like to do the first time the patient comes to you, if you have not been able to make a clinical diagnosis and the patient fever is not settling. Now, the complete blood count is possibly the most important investigation. And how would the hemoglobin help you? The hemoglobin would be low in malaria, but in our country it doesn't mean much, because the hemoglobin can also be low due to nutritional anemia. The hemoglobin, if it is high, it can be dengue, but sometimes the hemoglobin can also be high due to dehydration resulting from fever. So many times you have a patient with dengue and you see a hemoglobin of 15, and you think that the patient has a capillary leak. But the only reason the hemoglobin could be 15 is because the patient is having high fever for 2 to 3 days, is not drinking enough fluid, and is getting dehydrated. Then, what about the total WBC count? How does that help you in knowing the cause of fever? Now, if the total WBC count is very low or low, it could mean that the patient is having either dengue. It could be low or very low in many viral infections like influenza, etc. Or it could be low in malaria, or sometimes if the patient has very overwhelming sepsis also, you can have a low WBC count. The white cell count is usually normal in enteric fever or typhoid or paratyphoid. And if the white cell count is high, it could mean EBV, where the white cell count is high. It could be high in bacterial infections. It could be high if there is any inflammatory process, like, for example, Still's disease, etc. But we are not thinking of those diseases as a cause of short duration fever or in leptospirosis. So remember, in most tropical infections, your white cell count is normal or low, with the exception of leptospirosis, where your total WBC count is high. What about the differential count? If your polymorphs are predominant, it means it can be enteric fever. And contrary to what we think, even in viral infections, you can have predominant polymorph. Even in COVID-19, you get predominant polys. Lymphocyte predominance can be seen in viral infections, including EBV. And one important thing which I want you to look at is monocytes. We often forget to look at monocytes in a differential count, but if you see a monocyte count of 8 to 10%, that is a clue that you could be dealing with a viral infection, because sometimes the large lymphocytes which come in during a viral infection are counted as monocytes. So if you have a high monocyte count, that is a clue that you are dealing with a viral infection. And eosinopenia is not specific to typhoid. You can see it in any acute infection because there is a corticosteroid response. You can get eosinopenia. What about the platelet counts? If your platelet counts are very low, it again points to dengue, malaria, leptospirosis, or rickettsial infection. So especially in the monsoon season, if you do a CBC and you get a low platelet count, then automatically your mind tells you that you are dealing with a tropical fever. On the other hand, if your platelet count is low, it can still mean any viral infection. Even in acute viral hepatitis, even in influenza, you can get a low count. In typhoid fever, your platelets are usually normal. They start coming down in the second week, and any serious bacterial infection can also cause your platelets to go low, but they don't go to very low levels. And another important point which I wanted to make is the trend of CBC is more important than the single value. And day one CBC is usually normal in most cases. And that is why I said that when you are doing any investigation in a patient with fever, try and do it on the second or third day. And if you do a CBC on day one and it is normal, don't think that it cannot be dengue, or it can't be malaria, or it can't be lepto, because on the first day, the CBC is generally normal. Now, the next test which I would like to discuss is the C-reactive protein, because again, it's a very commonly prescribed test, and there are many myths about the C-reactive protein. The C-reactive protein is produced by the liver in response to cytokines, which are triggered by infections, trauma, and inflammation. So, any insult to the body, even if the patient has undergone a road traffic accident, your CRP will go up. Even if the patient undergoes surgery, the CRP will go up. Even if the patient has had pancreatitis, the CRP will go up. Another important thing which you have to bear in mind is because the CRP is produced by the liver, if the patient has end-stage liver disease, the CRP will not go up even if the patient is having an infection. Now, CRP has a diagnostic value, and the CRP also has a therapeutic value because the CRP helps in opsonophagocytosis. Usually, the CRP starts rising 6 to 12 hours later. It peaks at 48 hours and starts coming down in 72 hours. So that means if the patient starts having fever in the morning and you do a CRP in the evening, it will come normal even if it is a bacterial infection. And that is another reason why I said that when you start investigating a patient with fever, if you do the tests at 48 to 72 hours, you will get the maximum yield because, as I told you, the CRP also peaks after 48 hours. Now, don't ever do a qualitative test for CRP, whether it is positive or negative. You always have to do a quantitative estimation. The usual levels of CRP are below 10 milligram per liter. And that is one more thing which I want to tell you is labs report CRP in 2 units. Some labs give a milligram per deciliter value and some labs give a milligram per liter value. So you always, because sometimes what happens is that a patient does one CRP from one lab and another CRP from another lab. So if you're comparing the 2 CRPs, you can be misled. So always look at the units, whether it is milligram per deciliter or whether it is milligram per liter. And the usual cutoff is normal CRP is below 0.6 milligram per deciliter or 6 milligram per liter. Now you must remember, most people ask this question, that what is the cutoff of CRP which differentiates between a viral and a bacterial infection. Unfortunately, there is no such cutoff because there are certain viral infections like COVID, like adenovirus, where you have very high CRPs. But one thing you must remember that the higher the CRP, the more likely that infection is bacterial. So, for example, if you have a patient who comes to you with fever of 4-5 days duration and he has a normal white cell count and his CRP is more than 100, then you think that this could be a case of enteric. On the other hand, if the CRP is low or normal, then you think it is more likely to be a viral infection. So that is why there is a dynamic cutoff of the CRP, and you have to interpret the value of the CRP in light of the clinical picture of the patient. Now, many times what people do is that they say the CRP is more than 10, that means it's a bacterial infection. That is not correct because you can have more than 10 CRP even in viral infections. Repeating the CRP can also help you in judging whether the patient is having viral or bacterial infections, because if your CRP goes up after 2 days, then it means that this is probably a bacterial infection. And whereas if your CRP doesn't rise, it means it's probably a viral infection. CRP can also help you in monitoring the response to therapy, because if you've started antibiotics and the patient's CRP is declining, it means you're on the right track. So CRP is an important investigation, but its interpretation is tricky and you have to be careful with the interpretation. Now, I'm not discussing, so how do you interpret CRP in short duration fevers? Viral, there is mild elevation. In bacterial, it is elevated. In typhoid, it is elevated. In dengue, it is usually normal or just mildly elevated. In malaria, it is elevated. And in leptospira and rickettsia, it's highly elevated. So if you have a tropical fever syndrome, and I haven't put chikungunya here, but in chikungunya is a viral infection, but you have a elevated or a highly elevated CRP because there's a lot of inflammation in chikungunya. So you can see that if you have a tropical fever syndrome and you have a normal CRP, that means you're probably dealing with dengue. Whereas if you have a elevated CRP, then it could be anything. Remember that CRP should not be used to start antibiotic therapy, and a trend in CRP is more useful than a single CRP, and it is also helpful in monitoring response to therapy. Now, I have not included procalcitonin in my talk at all because really procalcitonin is not very useful in a short duration fever in a patient who's coming to you in the OPD. It does not give you more information than what a CRP gives you. So don't waste the patient's money in doing a procalcitonin. A CRP is good enough, and therefore I'm not discussing procalcitonin here at all. And because the only thing which is about procalcitonin is that it is secreted not by the liver but a variety of cells, and it rises in bacterial infections, trauma, tissue damage, but not viral infections. It rises in 2 to 6 hours, peaks in 12 to 24 hours, and declines in 24 to 48 hours. Its normal values are less than 0.5, and levels more than 2 nanograms per mil indicate serious bacterial infection. It is expensive, and it's not recommended in routine community acquired infections, does not add to information given by CRP, and it is negative in viral infections like dengue, COVID-19, and influenza. That means, let's say a patient has been admitted into your ICU with a tropical fever syndrome, and your CRP is positive, is negative, your procal is negative, then it is most likely he's having a viral infection. But as I said, routinely a CRP is good enough, and you don't need to do a procalcitonin. Now let us come to the next test which we would like to do for a short duration fever, and that is malaria. Now again, when we do a test for malaria, we again have to decide whether we are going to do a smear or whether we are going to do a malaria antigen test. Now remember, the sensitivity of the smear is, the thick smear is 10 to 100 per microliter, and that of an antigen test is 100 to 500 per microliter. So the sensitivity of the thick smear is better than the antigen test. Now, the species diagnosis can be done by the smear and the antigen test. Mixed infection can be detected by both the smear and antigen test. But the advantage of the smear is that it can tell you about the severity of the infection, because the smear will tell you whether it is what is the parasite index, whether it is 1%, 5%. With the antigen test will not tell you. Follow-up treatment can be told about the smear, because it can tell you whether the um, the smear has become negative, but the antigen test can remain positive for some time. And the smear needs expertise, whereas the antigen test does not need expertise, but you need to have a good enough kit and it has to be stored properly. And the smear is cheap while the antigen test is negative. So you have to decide whether you have a reliable microscopist available. If you have a reliable microscopist available, you do the smear. And if you don't have that person available, you do the antigen test. Now, earlier they used to say that if you are strongly suspecting malaria and your smear is negative, you keep repeating the smears every 6 to 8 hours. But now you also have the malaria PCR available. So you can do the PCR, because the sensitivity of the malaria PCR is 5 parasites per microliter, and the PCR is thus the most sensitive test. Now, another thing which I wanted to tell you is that the incidence of malaria is declining, and you should not give empiric antimalarial therapy. And this is just the malaria map. I wanted to tell you that these red are those areas where malaria is most common, which is in the northeast, Chhattisgarh, Jharkhand areas where it is very, very common. And remember that you should suspect malaria, especially if your patient is having falling platelet count, falling hemoglobin. And in those cases, if you're strongly suspecting malaria and your smear is negative, you can ask for the PCR test. Now, with that, I'm going to talk about another important, diagnostic test, and that is dengue diagnosis, because it's again a very, very common cause of short duration fever in our country. Now, you all know that dengue has various phases. That you have phase of fever, then you have a phase when the fever comes down and shock happens, and then the patient recovers. Now, you all know that when the patient actually goes into shock, the hematocrit rises and the platelet goes down. So, the most important test in management of dengue is actually the CBC. And what we should really be looking at the CBC is the hemoglobin rather than the platelet count, because the hemoglobin tells us if the patient is going to go in shock, because the rise in hemoglobin precedes the going into shock. And the other thing which you must remember is that the recovery in white cell count occurs before platelets. Now, this is again, I wanted to show you this this diagram, because you all know that in dengue there are two types of infection: primary infection and secondary infection. Second infection is when it happens with a different serotype of the dengue virus. Now, in primary infection, what happens is this is the this is what happens in primary infection, that you have the viremia which lasts for a longer time. This is when the NS1 antigen is detectable. And then you have the IgM response, which is in green. And then the pink is the IgG response. So you can see that the IgM comes up after 7 to 10 days, and then it drops down after a long time. And the IgG comes up later, and some amount of IgG remains for a long time. Now, what happens when the second infection occurs? You can see that the viremia is for a shorter time, and the NS1 also remains detectable for a shorter time. The IgM response is blunted, and the IgG response is very strong. The IgG antibodies are very strong. So this graph tells you that for dengue diagnosis, all three are very important: the NS1, the IgM, and IgG. All three are very important, because in secondary dengue, you have a small NS1 response, a small IgM response, and a very good IgG response. So, NS1 sensitivity is 70 to 90%. It decreases with advancing illness and in secondary dengue, and it is very specific. That means if your NS1 is positive, you can be sure that you're dealing with dengue. IgM is sensitivity is poor in early dengue and secondary dengue. And another important point you must remember that IgM dengue is not very specific. Many times you will see patients who will come with 2-3 days of fever. You will do NS1 and you will do IgM. The NS1 comes negative and IgM comes positive. That is not dengue. That is probably some other illness. And your IgM is positive because the patient had a subclinical dengue infection 6 months or 1 year earlier, and your IgM continues to remain positive. So if your NS1 is negative and your IgM is positive, beware. IgG dengue is again important because most of the kits, at least the good kits like PanBio, have detected only the IgG which is positive because of secondary dengue. So if you have a patient where NS1 is negative, IgM is negative, and IgG is positive, it means it could be secondary dengue, and this is the patient you have to be careful about. And that is why the guidelines say that no matter what time the patient comes to you, it is better to do both, all of them at the same time, IgG, IgM, and NS1. So, and again, you can detect all these by either doing a card test or a ELISA. And the sensitivity of the ELISA is better than the card test. So, I just have one, algorithm. So, if there is a case of suspected dengue, you can first do a card test for NS1, IgM, and IgG. It is a bedside test which you can do. And if your NS1 is positive, it means that the diagnosis of dengue is confirmed. But if your IgM and IgG is positive, then it means that it is probable dengue, but you should keep other diagnoses in mind. If all of them are negative, then you can do an ELISA for NS1, IgG, and IgM. But if that is also negative, then you should ask for a PCR because the sensitivity of the PCR is better than ELISA or card test. So, in fact, in the recent epidemics, when we were having a lot of dengue and chikungunya, we were often doing the dengue and chikungunya PCR combined because that was picking both dengue and chikungunya together. So if you are strongly suspecting dengue and your NS1 and all these are negative, you can actually do a dengue PCR. Now, coming from those investigations to urine, because if you have a fever with no other focus, it could even be a UTI or pyelonephritis. You can have no urinary symptoms. You can have back pain. So you should do a urine routine. And when you do a urine routine, you should look at the nitrite, you should look at the leukocyte esterase, you should look at the pus cells. And if the pus cells are more than 5%, high power field of centrifuged urine, it is significant. But remember, you can see pyuria just because of fever as well. And you must send a urine culture only if the urine routine is abnormal. And remember that you must send a urine routine immediately after collection, because if your urine routine is sent after 1 or 2 hours, the white cells will lyse and you may get a false negative urine routine. And if you're sending a urine culture, you must collect the culture properly after a midstream specimen with proper cleaning of the genital area, and it must be transported to the lab within 1 hour. Otherwise, you will get a falsely positive urine culture. Now, the next important test is a blood culture. Now, it is importantly in a patient who comes with a short duration fever, the main reason for doing a blood culture is to pick up typhoid fever. And you should do it if all other diagnoses are ruled out. And if you're thinking of typhoid fever, and you must collect it before you start antibiotics, you must clean the skin with 2% chlorhexidine, and you must at least send one set of culture. That means you must at least send 20 ml of blood in an adult. And if you send a culture in the first week of typhoid, your sensitivity is 90%, and then it drops with this. Another important thing we must remember is that Salmonella is a fastidious organism. So even if the patient has received 2-3 days of antibiotics, your pneumococcus will disappear from the blood, your Haemophilus will disappear from the blood, but your typhoid will still come positive. So, and many times the patient is on antibiotics like Oflox, Ciproflox, etc., which do not interfere with the recovery of Salmonella. And another important thing is that once your culture comes, you should interpret the results properly. Especially if you grow corns, if you grow pseudomonas, it may be contamination. And if you grow E. coli in the blood, it means that the probably, or Klebsiella, then you have to think that probably there's a urinary source of fever. And if you grow organisms like viridins group streptococcus, enterococcus, then you should start thinking whether the patient had infective endocarditis. What are the other tests you must do in these patients? Liver function tests. Because elevated bilirubin you can see in leptospirosis. You can get very high bilirubin levels, and mild elevation of OT-PT you can see in all tropical infections. Of course, if your OT is more than PT, it indicates dengue, malaria, rickettsia, etc. But if your SGPT or is more than SGOT and the values are in thousands, it mostly indicates viral hepatitis. If your albumin is low, it can be present in any cause of sepsis, especially dengue. You should also do a creatinine because it helps in choice of antibiotics. If your creatinine is high, it can indicate leptospira because many of these patients have non-oliguric renal failure. It can also indicate pyelonephritis or severe dengue. Then, after these tests, what are the other tests you would do? You would do an X-ray, and you will be surprised that sometimes your patient may just have very little cough. Your chest examination may not show you anything, and you may see a patch of pneumonia. I want to share an example of a colleague of mine who's 35 years old. She's a doctor. She had high fever for 5 or 6 days and a little bit of cough. And we did all her tests. Everything came negative. And her husband is a doctor who examined her clinically, and there were no signs. And when we did a chest X-ray, we found a large patch of consolidation, and she had actually a atypical pneumonia. So remember, the term used for atypical pneumonia is a walking pneumonia. So you may not get typical symptoms and signs. So any acute fever, if your initial CBC, malaria, dengue, urine is negative, you must do a chest X-ray because you may often find a patch and you may not really pick up any signs on auscultation. Then you must do an ultrasound abdomen and pelvis, and you may actually find liver abscess, you may find pyelonephritis. And sometimes I find an ultrasound abdomen and pelvis a useful investigation even in typhoid fever, because by day 5 or day 6, you might start finding splenomegaly, you might find terminal ileal thickening, and you might find presence of mesenteric nodes. And in some of our patients who come sick to the hospital with short duration fever, who are in multi-organ dysfunction or shock, we often do CT chest abdo because it may give us other diagnoses. Like in these sick patients, it may pick up a pneumonia, it may pick up pyelonephritis, it may pick up acute cholecystitis, and therefore this may be indicated in those sick patients who come to the casualty and who are admitted in the ICU. Then you may have to do some other tests depending on clinical suspicion. Like if you're thinking of leptospira, your patient is sick, is having high counts, low platelets, high bilirubin, high creatinine, then the best test to do is a leptospira PCR. If you're thinking of rickettsial infections, you should treat, not do tests, because the tests are not sensitive enough, but you could ask for a scrub typhus IgM or a wheal felix. If you're thinking of chikungunya, the best test is to do a chikungunya PCR in the first 7 days of illness, and after 7 days, you do a chikungunya IgM. Zika, again, we must think of Zika because it has come into India. So if you have a disease which looks like dengue, but your dengue is negative, even your dengue PCR is negative, chikungunya is negative, then you should ask for a Zika PCR in the first 7 days or a Zika IgM after 7 days of illness. Now, these have really come into the market, the tropical fever panel. In fact, you will see large billboards talking about the tropical PCR panels. And these panels test for dengue, leptospira, malaria, salmonella, chikungunya, West Nile, etc. Now, these panels are costing about 5 to 10,000 rupees. So the thing is that normally we don't ask for this panel upfront, because most often you can make a diagnosis on the basis of your NS1 or your malaria parasite. So, and if you're really thinking of leptospira, you can ask for a standalone lepto PCR. If you're thinking of chikungunya, you can ask for a chikungunya PCR. So that is why I think that you should do this panel only if your patient comes to you really sick and you can't make out whether this is dengue, malaria, leptospira, chikungunya, whatever, then you may send this panel. But more often than not, with your initial basic investigations only, you can, or the clinical picture, you can somehow make a diagnosis. So I'll just share quickly now in the next 5 minutes some cases. For example, the 62-year-old came to us with fever for 3 days with burning micturition. Day 4, he had no fever, but he started feeling weak. And day 6, he was admitted to a hospital with shock and bilateral pleural effusions. And when his counts were done, it was 13.4 hemoglobin. Total count was 24,000 and platelets were 296,000. CRP was normal, Procal was negative. Urine routine was 5 to 10 pus cells. Now, normally, somebody would think that this is like urosepsis. So counts are high. He had burning micturition. But what was odd was that his CRP and Procal were not high. Dengue, malaria was negative. Blood culture was negative. Even one would not think of dengue here because his count was high, platelets were high. But the whole disease was not fitting into anything. So a molecular panel was sent and it was actually dengue positive. And you would think of dengue because he had shock and he had bilateral pleural effusions. So it was not fitting into classically into anything. It was not even fitting into urosepsis. It was not fitting into dengue. So this is the place where, some of these panels may help you. And this is also somewhere which will tell you that dengue may not come with characteristic leukopenia and thrombocytopenia, which we always think it will come with. So always be ready for some such surprises like this. Now, I'll just tell you about molecular tests for respiratory infections because we are talking about undifferentiated fevers here. So sometimes remember that even in the first few days, even an influenza or COVID or adenovirus will come with undifferentiated fever. And therefore, sometimes you may even have to do a nasopharyngeal swab to pick up these respiratory viruses. Now, there are some other tests which are done but are not useful. For example, ESR. ESR has no value in a short duration fever because high ESR is non-specific and you can have any fever with a normal ESR. Vidal is of absolute no use because it doesn't rise for the first 7 days and it can be 1:80 titer can be seen in many infections and any cause of fever can cause the Vidal to rise. Typhi.IgM or Salmonella IgM is again absolutely of no value in diagnosis of typhoid. So please do not ask for any of these 3 tests when you investigate a short duration fever. Now let us see some cases. Now suppose I want you to think in your mind, what do you think this could be? Hemoglobin of 12.3, count of 3,900. Look at this. 60% polys, 18% lymphos, 10% monos, platelets 1,40,000, CRP 20, dengue negative. What do you think this could be? 3 days fever. Anybody? Actually, it can be anything, but it is mostly viral. Why do you think it is viral? Because look at the monocytes. Look at the WBC. It has dropped in 3 days only. In typhoid, your WBC will not drop and platelets will not drop so much in the first 3 days of fever. So it's most likely some kind of viral infection. Now look at this other case. 3 days of fever, count of 20,000, platelets of 67,000, CRP of 200. Dengue IgM positive. Do you think this is dengue? What is odd for dengue? Your CRP being 200, the count being 20,000. Of course, you can have dengue with high count because bad dengues can come with leukocytosis, but this is more like leptospirosis. Because as I said, in lepto, you get high counts, you get low platelets, and you get high CRP. This is one tropical fever with high WBC count. Now, again, a third case. Fever for 3 days, no focus. Look at the WBC count. 5,600. Platelets 2,10,000. CRP 60. Dengue rapid negative. What is this? Malaria, enteric fever, chikungunya. Can be either typhoid or chikungunya, because here again your CRP is high. So this can even be chikungunya, this could even be typhoid. So this is just to tell you that 3 days of fever, it can be anything. It could be any of these fevers. It could be typhoid, it could be chikungunya, it could be dengue, it could be malaria, it could be leptospirosis. But if you do a CBC or CRP, it can give you some sort of clues. So I think with that, I would like to end my presentation saying that acute undifferentiated fevers are a common clinical problem. The etiology varies with season and geography. The initial approach should be to do a careful clinical examination and history. Investigation should be delayed to 48 to 72 hours unless the patient is very ill, and they should be guided by clinical differentials. The basic test should be a CBC, CRP, urine routine, malarial parasite, and in the monsoon, dengue serology. And for typhoid, the gold standard is a blood culture, and you should not do a typhi.IgM or typhoid IgM or Vidal. And once your results come in, you should interpret the results carefully, and then you should use these molecular tests judiciously. I think with that, I am done, and I would like to turn over to the moderator. Thank you so much.
Thank you for your wonderful presentation as usual. Going to be very helpful for our doctors. We have a lot of doubts coming in from our doctors, and we will be getting into that. So one of the earlier questions that we had, it was from Dr. Kulkarni. Is amoebic hepatitis a common presentation in pediatrics with fever?
No, it is not. It's very uncommon. A liver abscess can come, but most of these liver abscesses are bacterial.
Moving to the next question from Dr. Ravindra. Can we treat acute fever only with antipyretic without antibiotics?
Absolutely. So that is why our approach is that when a child comes with fever or an adult comes with fever, for the first 1 or 2 days, you should just give paracetamol and wait and see what happens over the next 2 to 3 days. And most of these fevers will actually be viral infections, and you don't need to give them antibiotics.
There was a question from Dr. Neela. Can USG diagnose pyelonephritis, or do we need plain CT scan abdomen and pelvis?
Yeah, USG may not be very good for pyelonephritis unless you have a renal abscess. So I think the diagnosis of pyelonephritis is more by symptoms. So if a patient has fever and has pain and has urine showing pyuria, it would indicate pyelonephritis, yes. But you're right, CT is better than USG to pick up pyelonephritis.
So the next question is from Dr. Gupta. Can we use NSAIDs in severe joint pain in dengue fever with thrombocytopenia, or is it better to use paracetamol?
So actually, the recommendations are to not use NSAIDs in dengue with thrombocytopenia because the bleeding risk is high. So you would have to use paracetamol. You could use a higher dose, 15 mg per kg, but NSAIDs are contraindicated. You could use tramadol if you want to.
Another question from Dr. Gupta was, what is the best medication to treat leukocytopenia in dengue fever or other acute febrile illness?
No, you don't need to do anything for that because studies have shown that this leukopenia does not increase the risk of secondary bacterial infections. So you don't need to give them GCSF. You don't need to give them prophylactic antibiotics. So you just let it recover on its own.
Next question from Dr. Maheshwari. What is the role of false positive and false negative reports in present time investigations?
Yes, so as I said that all tests have their limited sensitivities and specificity. So there won't be any test which is 100% sensitive and specific. So you will have to understand that you may have a condition where you have done a test and the test may come negative and yet the patient may be suffering from the disease. So that is why you have to keep that in mind and be aware of that and understand the limitations of the test that you have done. And there will be those situations where the patient will be having your disease and the test may come negative. That is why there is a need for having good clinical acumen.
Next question is from Dr. Ambaram. All bacterial infections are nitrite positive in urine. In some UTIs, nitrites are negative, but culture and sensitivity of urine is positive. Any view on this?
Yes, so actually nitrites are only positive if the bacteria can convert nitrate to nitrite, and second, if the urine stays long enough in the bladder for it to be converted. So if the person is having a lot of dysuria and frequency, your nitrite may be false negative. Or if the infection is with a bacteria which does not convert nitrate to nitrite, will be false negative. So remember that nitrite is sensitivity is low but specificity is very high. So if your nitrite is positive, then you are very sure that you are dealing with a UTI. But a negative nitrite does not rule out a UTI.
So the next question from Dr. Ratandeep. If a patient had typhoid fever in the past, then which of this indicates previous typhoid fever infection, Salmonella typhi O or H?
Any can be positive both, although it's O most likely because O is IgG and H is IgM. But actually, in Indian setting, either both of them can remain positive for a long time.
So the next question from Dr. Srivastava. Which drugs are the best for chikungunya with severe joint pain?
So actually, normally we try to use NSAIDs in the acute phase. So you can use drugs like ibuprofen or you can use naproxen. But some patients actually need even steroids, hydroxychloroquine, especially those in whom the joint pain continues. Joint pain continues for a long time. Most rheumatologists actually treat with deflazacort, low dose deflazacort.
So doctor is taking in the last three questions for tonight. Next is from Dr. Ravichandran. What are the tests to do to detect for dengue shock stage?
No, so that is a clinical diagnosis. So dengue shock diagnosis is a clinical diagnosis because the patient will have tachycardia, the patient will have a low, narrow pulse pressure, the BP will be low. I mean, those things will be there. And as I said, that's a clinical diagnosis, but the lab tests remain the same: the CBC, the dengue, NS1, IgG, IgM. But for detecting dengue shock, you have to rely on clinical parameters.
Next question from Dr. Malvia. Are co-infections common against malaria, dengue, and chikungunya?
They are an exception rather than the rule. And many times, people think that there is a co-infection because they have done malaria. Malaria is positive and dengue IgM is positive. So they think there is a co-infection. But most of the times that other serologies are false positive. It's very rare. Uncommon, I would say.
Doctors, in the interest of time, taking in the last question. It is from Dr. Soham. Within the first week of fever, if malaria, dengue comes negative and other viral causes ruled out, and fever is not subsiding even on antibiotics, do we wait for the blood culture if typhoid is suspected? And why is typhoid not useful in the initial phase?
No, so as I said, that then you should make a clinical diagnosis of typhoid fever, send a blood culture, and start the patient on antibiotics. So why would you even do a typhi.igm? Then you have made a diagnosis of enteric fever. So you don't do a typhi.igm. Then you start the patient on antibiotics. Because the specificity of the typhi.igm is poor. And you can have some other disease and the IgM comes positive. We did a study of 23 patients with culture positive typhoid and one IgM was positive. The rest it was negative. And you can have some other cause of fever and the IgM comes positive. So as I said, why do the IgM at all? If you're clinically suspecting typhoid after you've ruled out other causes and you've sent a blood culture, then you are absolutely justified in starting antibiotics for the patient without a typhi IG.
Thank you, ma'am, for taking in our questions. With that, I would also like to mention that there's a lot of appreciation coming in for you for this session. Our doctors really loved it, and thank you once again for this session with us. Really hope to see you again on Netflix. Thank you once again, ma'am.